I work at MIT as a principal research scientist. The focus of our research is on secondary use of electronic health records. But I also work as a medical doctor at Beth Israel Deaconess Medical Center, which is one of the hospitals in Boston. I work in the intensive care unit. And I'm going to start off with a slide that I typically end the presentation with. And I'm just going to read a quote from this paper that we published last year. For a true data revolution to occur in healthcare, we must become better at sharing and integrating data. Greater emphasis on collaboration outside the traditional multidisciplinary realm and into the engineering, mathematical, and computer sciences will help us to achieve this. And the most pressing problem really in being able to move the field of machine learning and artificial intelligence in healthcare is not the technology. It's primarily social, it's primarily political. It's bringing together people with different backgrounds. And I'm pretty sure that the people here are very much familiar with the problems of bringing together expertise from different disciplines. I wanted to start with the flagship project of our group, and that is a database of patients being admitted to the intensive care unit. It's called MIMIC. It stands for the Medical Information Mart for Intensive Care. And it contains all the data that is being obtained for patients who are admitted to one of the several ICUs in the hospital where I worked in. So it has vital signs, it has laboratory results, all the medications and interventions are time-stamped, all the notes are captured, and starting this year, we're going to be putting in images. So we're going to be dumping about 500,000 of chest x-rays that are linked with the electronic health records of the patients. And when we first started the project, we did something which was novel at that time. We made the data completely accessible to everyone. So we removed protected health information, and the only requirement is for users to sign a data user agreement that they're not going to try to re-identify a patient. And we have close to 10,000 users now from all over the world. It's being used by courses across the country and across the globe in teaching concepts about machine learning and medical informatics. But this is a single-center database, and we are all aware about the limitations of a data coming from one center. So 3 years ago, we partnered with Philips, and they made us the warden of a much larger ICU database coming from more than 400 hospitals in the United States. And same as MIMIC, we decided to open access a subset of that database with more than 200,000 patients. We are not content with just providing the database. We want to make sure that we're training the next generation of data scientists and clinicians who could leverage the potential of these data sets. So during the fall, we teach a course at MIT called Collaborative Data Science in Medicine, where we interface computer science students, data science students with clinicians from all around Boston, as well as hospitals from other parts of the country. And this becomes now a pipeline of research studies, as well as projects involving development of prediction algorithms. And we're hoping to transition this into an edX course very soon. We wrote a textbook, and it's a cookbook. How do you start off with a research question and go into an electronic health record database? And in the true spirit of MIT, we made the book completely free to anyone who wants to download it. So during the first year, it was downloaded 100,000 times around the country. But we felt that it wasn't enough to provide a data set. It wasn't enough to really develop the next generation of workforce that would leverage the value of the data. It's important to work on the culture. So every month we actually travel around the world, and our mission during these trips is to interface the data scientists with the clinicians, the doctors, the nurses, the pharmacists, and make them get used to this environment where they're able to really leverage or take advantage of each other's expertise. So we hold this what we call datathons. These are data marathons where the teams would come up with some research questions, or would come up with some pain points in the practice of medicine, specifically in critical care medicine. And over a weekend, they're able to do as much analysis as they could. And the output of these events would be a publication or perhaps a software that could be patented for introduction into clinical workflow. So we were in Beijing last November. We partnered with one of the biggest hospitals in China, the People's Liberation Army General Hospital. We are slowly able to convince them that sharing their data is really in the best interest of their patients. Initially, they were just working with our data set, and we told them that it's fun to play around with Mimic or Philips data set, but at the end of the day, you're not guaranteed that the models that you build using our data would be applicable to the Chinese population. So they started building their own version of the database, and we're hopefully we'll be able to get permission to open that to the rest of the world. Most recently, we were in Japan just last month, and what we're doing now is partnering with professional societies, convincing them that the next generation of clinicians have to be more data analytics savvy. And the same thing with the data scientists. They need to be able to have access to the clinicians who are able to come up with more relevant questions to work on. But we're not just focusing on high-income countries, which are the ones who have electronic health records. What we don't want to do is to contribute to the divide in the health outcomes of people who live in rich and poor countries. So we have an arm in our group called SANA, and the focus of this group is to assist our partners in low and middle-income countries in designing and implementing a digital health platform. So at present, all their health data is primarily in paper format. We wanted to move that into a machine-ready format so that you could start applying methodologies of machine learning. We also have a course on global health informatics. This one is every spring, and this one is actually running longer than our course on secondary analysis of electronic health records. The course has been pushed to edX, so we get students, learners from around the world. And we also publish a textbook, an open access textbook, to accompany the course. This spring, the focus of our course is on big data in global health. How can you leverage data to track and do disease surveillance? So typically, the way we track infections, such as Zika virus, has been more laborious because it requires input of data from healthcare organizations. But could we leverage other types of data, non-traditional data, to be able to characterize how an infection is traveling through across different borders? So we partnered with a group called Health Maps based at the Children's Hospital at Harvard Medical School, and providing some hands-on workshop in looking at data that you could get from the internet, data that you could look at from the social media, to be able to look at questions that are related to health, such as infectious disease surveillance or even drug adverse events. I'm going to dive in now into what I'm hoping to cover over the next 20 minutes. And the first key message is that technology alone cannot fix the problems of healthcare. And this is something that I emphasize to the students and our colleagues at MIT who tend to be very much focused on technology, thinking that technology could transform healthcare. And then the students would always come to me, well, what are the problems of healthcare? What are the problems that we need to solve? And the good news is that it wasn't difficult to give them a list of what the biggest issues are in healthcare, not just in the United States, but also across the world. And the answer that I give them dates back to 1989. In 1989, the Agency for Healthcare Research and Quality was established in response to a report given by the Institute of Medicine. And in that report, they cited the biggest problems in healthcare as, number one, escalating healthcare costs, number two, wide variations in medical practice patterns, and number three, evidence that some health services are of little or no value. Fast forward to 2018, we have exactly the same problems. It seems like we haven't done any progress in trying to address the biggest issues in healthcare. So the first problem that they talked about was the cost of healthcare. And for some reason, healthcare is very different from other industries. In other industries, as technology becomes better, the cost becomes lower. This is a great photo. On the left side is what a 5-megabyte hard drive looked like in 1956. And just to remind people, a 5-megabyte hard drive could contain one song. In 1983, if you want to buy a 5-megabyte hard drive, it costs close to $3,000. Fast forward to 2018, you could buy a 128-gigabyte hard drive for about $20 on Amazon Prime. And just to remind people, 1 gigabyte is 1,000 megabytes. Again, this is a great example of how technology had lowered the cost of that technology, but not in healthcare. As we're really discovering new technologies and we're incorporating that into healthcare, the cost continues to skyrocket. One of the reasons that we give why healthcare is so expensive is that there's so much waste in healthcare expenditures. So data from 2009 show that for every dollar that we spend in healthcare here in the United States, 30 cents has no value. And that's probably an underestimation of the waste that we have in healthcare. And one of the factors that contribute to waste is really the concept of overdiagnosis and overtreatment. This is a book that I highly recommend. It's from Gilbert Welch, talking about overdiagnosis and overtreatment. A paper from Atul Gawande talked about how much laboratory testing we're doing in the United States, how we do so much CAT scans and MRIs. So every year from data in the early 2012 and 13, I believe, the United States would perform 10 billion laboratory tests per year, 100 million CAT scans and MRI scans, and 15 million nuclear medicine scans. Do we need all this? And or do this contribute to this phenomenon of overdiagnosis and overtreatment? So overdiagnosis is actually not a wrong diagnosis. It's the correct diagnosis of a disease that is never going to bother you in your lifetime. And one of the examples that is typically given for overdiagnosis is thyroid cancer. In the United States, because of the technology of ultrasound, the number of thyroid cancer detected has tripled over the last 2 decades. In Korea, it is now the most common cancer diagnosis, and they've seen a 15-fold increase in the detection of thyroid cancer. But if you look at deaths and morbidity from thyroid cancer, you have not seen any change in either the United States and Korea, despite the fact that we're diagnosing more of it, we're catching them earlier. Overtesting, we think, is going to get worse over time. It applies to increase in monitoring from wireless sensors and other new gadgets. We're discovering more and more omics biomarkers. And as more sensitive technologies turn up, we're going to find more abnormalities that aren't actually causing problems and never will. And for informaticians like us, this creates a trail of data that we currently don't know how to interpret. Moving on to the second problem that was highlighted by the Institute of Medicine report in 1989, which is that of care variation. This is a quote from Arnold Relman, who was a former editor-in-chief of the New England Journal of Medicine, one of the probably the highest impact medical journals. And he says, many people think that doctors make their recommendations from a basis of scientific certainty, that the facts are very clear and there's only one way to diagnose or treat an illness. In reality, that's not always the case. I would say that's never the case. Many things are a matter of conjecture, tradition, convenience, and habit. This, of course, is Vinod Khosla. He's a venture capitalist, and over the last decade, he's been investing a lot of his money into healthcare. And during one of his interviews, he was asked, what did you find most astonishing when you started looking at healthcare? And he said, what amazed me the most was how bad healthcare is. And he goes on to describe a research experiment where they gave a case vignette, so a description of a patient with all the symptoms, the duration of symptoms, and all the tests that have been done on that patient. And they gave that case vignette to 40 seasoned cardiologists from around the United States. So these are highly experienced cardiologists. And there was only one question at the end of the vignette. Does this patient need open heart surgery or not? And you would think that there would be a consensus, and it was 50-50. Half the cardiologists said this patient needs open heart surgery, and the other half said, no, medical treatment is best for this patient. And that wasn't the end of the research. They came back to the same cardiologist 2 years later, gave them exactly the same case vignette, and 40% changed their minds within 2 years. So it's very unnerving to think that whether or not a doctor will recommend open heart surgery to you will depend on which doctor you're seeing, and it may also depend on the timing. So care variation results from several reasons. The first is there is variability in doctor training, knowledge base, and experience. But there are also so many uncertainties and information gaps in the practice of medicine. And finally, we're all aware that biases exist among both the doctors as well as the patients. And AI holds the promise in trying to reduce this care variation. The application of AI may reduce variability around complex clinical decisions that are not explained by patient factors or clinical context. It has the potential to move clinical decision-making from intuitive to data substantiated, from the realm of art to a domain of science. This is a very compelling reason why we need to really take advantage of the data that is being collected in the process of care. This comes from Thomas Frieden. It was from a commentary that was published in the New England Journal of Medicine in the fall of last year. For much and perhaps most of medical practice, randomized controlled trials-based data are lacking, and no RCT is being planned or is likely to be completed to provide evidence for action. It leaves practitioners like us with large information gaps for most conditions and increases reliance on clinical lore. So we have been in this domain of trying to leverage healthcare data, applying machine learning, and developing artificial intelligence tools. And these are some of the key messages that we've learned along the way. The first is that the breakthrough in artificial intelligence are a result of dumping big data, and I highlighted big data there, into decades-old machine learning methods and not from advances in algorithms. So the methodologies that we're employing now have been around for quite some time, but the biggest difference is that we now have high-resolution data, and we now have this data in really massive proportions to be able to apply those methodologies. But the second message, I think, is more important. Adoption of AI in healthcare will depend not on performance metrics. So I always scoffed at papers that would highlight their AUC. And to clinicians, AUCs don't matter that much. What we're after is how that artificial intelligence algorithm will impact on relevant clinical outcomes and would hopefully improve the satisfaction of both providers and patients. I'm just going to go over a project that I'm involved with, and this is the application of reinforcement learning to hopefully optimize decision-making in the intensive care unit where I work. So one of the hallmark of being very seriously ill is having a low blood pressure. And there are two interventions that you could use to address hypotension or low blood pressure in the intensive care unit. The first is giving you fluids through your veins, and the second is using medications to bring up your blood pressure. And on a daily basis, we do it very ad hoc. So the team that's taking care of the patient would have their decision based on how they really bring together the data that surrounds the patient. But there are no formal guidelines that this is exactly what you have to do for this particular patient in terms of how much fluids to give and how much to titrate that medication to bring up the blood pressure. So what we're hoping to do is use the reinforcement learning in trying to optimize those decisions. Reinforcement learning is similar to what we're doing here with the mouse, who is placed in a maze, and then the mouse has to make decisions in terms of which way to take. And at the end, there are two things that could happen to the mouse. Either the mouse would be able to reach the cheese, or the mouse would get electrocuted. And what we would like to do is to see which decisions that the mouse makes would lead the mouse to either the cheese or to being electrocuted at the end. So in this case, we have a patient that gets admitted to the intensive care unit. Every step of the way, we make decisions. Specifically for the problem that I mentioned, we make decisions in terms of should we give fluids, how much fluids should we give, should we start the patient on a medication to bring up the blood pressure, Should we titrate that medication? And each step of the way, we are trying to optimize an outcome. And the outcome could be the patient goes back home fully functional, or the patient dies at the end of the hospitalization. And this involves a Markov decision process, which is a general framework used for modeling sequential decision making. And basically, the whole problem is defined by a finite set of states. So these are states of the patient as the patient travels through the intensive care unit day to day, or hour to hour, or minute to minute. A finite set of actions, which for our problem would be the fluid and the dose of the fluid administered, the medication to bring up the blood pressure. There's the transition matrix, looking at how a patient goes from one state to another, and finally, the immediate reward that you would like to optimize. And the outcome could be chosen really by the investigators who are involved with the study. And what we would like to do is to model the prescription of intravenous fluids and vasopressors using a Markov decision process. And using machine learning, we were able to identify 750 states that a patient could be in as the patient travels through the intensive care unit. And this is by the use of k-means clustering of time series of 52 variables up to 72 hours of data per patient. And what we would like to be able to do using reinforcement learning is to identify optimal decisions from one state to another, looking at optimizing whether they're dead or alive at 90 days. So you could, again, prescribe whatever outcome you're interested in. For this study, we decided to only be concerned at whether they're dead or alive at 90 days. But you could change that. You could look at whether they're functional at the end of being discharged at the hospital. You could look at whether they have any cognitive deficits. So it will be up to you in terms of what reward you would like to optimize. We built the models using the MIMIC data set coming from Beth Israel Deaconess Medical Center, and then we validated the performance of the model on a separate data set that was not used in the training, which was the Philips EICU database. And indeed, we were able to find an optimal dose of fluids as well as vasopressor as the patient goes from one state to another that was associated with the lowest mortality at 90 days. And the model validated well in a separate data set, the data set coming from the Philips. And what we try to do now is to do some simulation. What if the doctor had access to this optimal decision? What would have happened if the doctor was able to learn from the computer what should be the dose of the fluids, what should be the dose of the vasopressor? What would have happened to the mortality of the cohort? And it turned out that if the doctors follow the advice of the computers, we would have seen a drop in the mortality rate from 17.7% down to 9.6%. And I would tell you that a reduction, an absolute reduction of 8% is huge in the intensive care unit, especially if you start multiplying that with the number of people who are getting admitted to the intensive care unit. I'm gonna end my talk about some of the caution that we need to really undertake when we're applying machine learning into big data. So the pitfalls of big data are no different from the pitfalls of statistics, except magnified. The first example that I would tell you is an exercise that was provided by the Center for Open Science. So what they did was they have this huge data set of football games or soccer games. And in that data set, they have referees handing red flags. And we also have the ethnicity of the soccer player. And the question to the research teams is that, are referees biased? Are they more likely to hand red flags to players who are collared? And this data set was given to 29 teams. And again, these are not novice research teams. These are teams consisting of statisticians and machine learning experts. They're free to use whatever method they want to be able to answer the question, but they will be using the same data set. And again, you would think that they will have the same answer because they were using the same data set, but of course, that wasn't the case. The effect size was all over the place, the confidence intervals were all over the place. So it just shows you that your methodology in terms of answering a question or building a model will have a high impact on what the answer would be or what the model would be, even though you're working with the same data set. Another big issue now in the field of artificial intelligence is machine bias. So we think that if computers are able to assist us, they will come up with more objective decisions. They will give us with more objective suggestions or recommendations. But it turns out that if you feed a computer biased data, you will get biased decisions. So this is a paper that was published by ProPublica about 3 years ago now, where they examined a software that is being used by judicial courts across the United States. And the software is meant to assist judges and courts in terms of setting bail, as well as in terms of making decisions about whether to grant parole to a prisoner. And they looked at the data. Some judicial courts were following the advice of the software, and some were not. And when they looked at the software itself, it turned out that it was particularly likely to falsely flag black defendants as future criminals, wrongly labeling them at almost twice the rate as white defendants, and that white defendants were mislabeled as low risk much more often than black defendants. So this really highlighted this issue of machine bias. How could this translate to healthcare? There are a lot of use cases where we could see this playing out in healthcare. We could have algorithms predicting response to treatment that could be biased against certain groups and may suggest withholding those treatments from those groups. And increasingly, I think we're going to be seeing this. You could also have algorithms predicting prognosis that could be biased against certain groups and may suggest premature termination of treatments. I think I'm gonna finish up pretty soon. I'm gonna end up with a quote from Nick Bostrom, and this is obviously very relevant now in light of what we know about Cambridge Analytica. The pressing ethical questions in machine learning are not about machines becoming self-aware and taking over the world, but about how people can exploit other people or through carelessness introduce immoral behavior into automated systems. And with that, I'm happy to answer any questions. Thank you.
So I'm going to start. So with the last critical care model that you developed for survival versus non-survival, you had a tremendous number of patient stays, like 750 or something like that, and a lot of other parameters. So how underdetermined was your model, or was it underdetermined? How many patients did you have to be able to resolve that many states?
I think we have the table 1 here. Oh, I didn't put the table 1. But the original cohort for Mimic is we have about 60,000 ICU admissions.
Yeah.
And then for Philips, we have about 3 million ICU admissions that we used.
3 million is a lot.
Yes.
Yeah.
And I think that really is the case for big data now. As you are looking at a much larger set of candidate variables, and I'm pretty sure the genomics people are very well aware, if you're talking about 3 million features, you're going to have an order of magnitude in terms of sample size. Like, you can't be working with 10,000 sample size. You can't be working with 100,000 data points. We have time series data on more than 1,000 variables. So you need millions, tens of millions of patients to be able to build robust models.
That's impressive. Yeah.
Can you characterize the differences that you found between your data set and the Chinese data set? Are they cultural? Are they nomenclature? Are they different priorities?
There are tons. And I could tell you that 90% of our work is data harmonization. So it's not just the difference in practices, it's how they capture the data. There's no such thing as data standardization at present. So again, 90% of the work that we're doing is in harmonizing the data, applying as many standards and many accepted ontologies as you could to the data. And we need more help. Like, we can't be doing this. That's why we're big proponents of crowdsourcing what we're doing. Because this is a huge problem. People think, oh, we have tons and tons of data and we could just apply machine learning. Like, no, that's not the way it works. Otherwise, we would have solved all the problems last year or 2 years ago already.
So are you standardizing the Chinese data to your formats? Is that?
Yes, so what we're doing now is moving all the different databases using the OMOP format. And OMOP is a data schema where what they had in mind when they designed the schema is be able to perform clinical research. So somehow it will be easy to extract concepts using OMOP. But even OMOP wasn't designed specifically for critical illness, where you have time series data for a lot of variables. So this involves us working with our colleagues from all around the world to be able to help in terms of the mission is to move everyone's database into OMOP format so that we could link the data elements. But even if you link the data elements, again, there would be some nuanced differences with how people are collecting their data that will be important in developing these models and validating these models. So I think our journey has just started. We're not saying that we have made tremendous strides in this field. I think we're really just starting the journey.
Are you, in light of your comment on bias, are you looking for biases in the systems you're designing to try to eliminate them?
Yes, we're always paranoid that if we come up with a model, that it will perform differently across different populations. And that's why we're always trying to run the models on specific populations, especially those that are marginalized. So there was an initiative that was launched at MIT last summer called AI Now, and this is in partnership with ACLU, and really focusing on making sure that you're not marginalizing some populations, even worse, when you're applying your algorithms. I was just reading a paper about a software that is being used to calculate the number of hours that someone would require some help with, and it turns out that that algorithm was, again, flawed, and when they asked the company, well, we have to see why it was giving us the wrong decisions for a lot of patients, and they said, well, it's a black box artificial intelligence algorithm. We can't really tell you how the decisions are being made. And I don't think that that is going to fly. I think we have more understanding that this black box algorithms could be biased, and the only way to understand how they could be biased is to be able to understand how they are able to spit out their predictions as well.
Right, thank you.
So I go? So thank you so much for reminding us the red flags when we are thinking about deep learning and AI in healthcare. Let's leave the control environment of ICU and go in another big problem that is chronic disease, essentially either prevention that we are very interested in or diagnosis and therapy afterwards. In this case, actually, I have two questions. Number one is about outcomes. What will be considered an outcome there? For instance, I can give you a medication to reduce your blood glucose, but at the same time, you gain weight, your quality of life is reduced. So can you see there models, what can be models that we can use for something like this? And the second is how we monitor and how we ensure the data that we collect when it comes to lifestyle, when it comes to the life outside the hospital walls.
So I'm very much aware of the time, and I could be talking here for hours trying to address your questions. So we also have an interest in trying to include non-clinical data. So right now, our models are only looking at clinical data, what medications they're taking, what interventions are being done. But we know that social determinants of health are contributing even more to the outcomes that we're interested in. And as regards the outcomes, a lot of the outcomes that we're really interested in are not being captured anywhere right now, and we have to be more creative in terms of how to get hold of the outcomes that are relevant to patients. But I think we have a panel discussion later.
Yeah, let's have one more question, then I know there's a lot of interest in this, but we have a whole panel after this, so one more question, then we'll move on.
Yeah, very quickly. So in your Markov model, that's a black box approach, right? and it's fully agnostic of molecular and physiological and cellular processes. But do you think if that works, that we can essentially forget about science and just do these kind of things?
I don't
that
think
would
so.
change totally the landscape of education.
I don't think so. There's now AI to understand AI better. So there are so many methodologies now improving the interpretability of AI, where you're removing one variable at a time and see what's happening to the precision of your models. So I think we're going to be understanding black box AI algorithms in the future.
Well, but so there are two black boxes. One is a neural network black box in identifying the nodes. The other is a scientific black box, right? The human body is also a black box. So I don't think that can be solved by the identification problem.
Yes, that's correct. But I'm hoping that we improve our understanding even of human physiology. People always say, well, what is the mechanistic reasoning behind this model? If it's not supported by what we know about physiology, then we can't accept it. The problem is that physiology is also based on data. Like, what we know about physiology was based on experimentation with animals back in the 1950s. And it's right, I think, for us to question what we have embraced, the physiologic concepts that we've embraced all along, that maybe they don't really apply to our patients in the intensive care unit. And we now have data to try to understand that physiology better. Thanks.